My name is Michael Hebb, and I'm the founder of EOL and the founder of Death Over Dinner. And this is our weekly session called Ask the Doctor, where we sit down with a brilliant doctor and talk about end-of-life issues. And we talk about a different topic every week. And today we're with Dr. Anthony Bossis, or Tony for short, who is a professor at NYU School of Medicine and a leading researcher, and has been for a long time, in the psilocybin and psychedelic medicine space. Tony, thank you for being here with us.
Michael, great to be here. Pleasure. And thank you for the work you're doing and bringing awareness of this to everyone. Thank you so much.
It's an honor because I get to work with folks like you. We're going to start with not a question about psychedelics, but a question about death anxiety, because a lot of the work that you do has been centered around death anxiety and other things that we face. But let's start there. What is death anxiety? What have you learned about it? How do people know if they have it? And how does it show up in their lives?
Great. Thank you, Michael. Yes, this is it's been my primary interest in the psychedelic treatment space. And predating that is a longstanding interest in palliative care and working with patients at the end of life at a palliative care center. So it's important to bring awareness to this. So it's important to also separate things that are somewhat not true. Because one is dying doesn't necessarily mean they need to be majorly depressed, although that often is the place at the end of life. But we know that depression, hopelessness, demoralization, which I'll talk about in a moment, can be treated at the end of life. Sadly, hopelessness and depression, when untreated, can lead to a desire for a hastened death. And we see a growth now in these physician-assisted suicide models that I think deserve conversation. And so what is this distress? Well, clearly it's something we all could relate to. It's that fear of non-being. It's the fear of leaving this one life we have here. It's an increased sense of anxiety and demoralization, which is hopelessness, which is existential distress, which is just fear. It comes with many risks, both psychologically and medically, in terms of desire to have a hastened death because of these experiences. And it's often not discussed. Ernest Becker, The Denial of Death, I think it's just, we've gotten better at it because of people like you bringing awareness to the culture, but it still remains a bit out of the cultural conversation. The end of life is part of life, and we need to talk more about it. But it's to be with people as they're suffering at the end of life, and to see changes, by the way, because of this treatment and other meaning-making approaches, is profoundly heartening.
Yeah, absolutely. And so now let's introduce psychedelics to the conversation. Probably a lot of people on the call have an idea about what psychedelic medicine means or what it is. But for those that don't, and just for clarity's sake, what do we mean when we say psychedelic medicine?
Great, thank you. So psychedelics are a category of compounds that, when humans take them, can generate this very dramatic shift in consciousness for a short period of time, a few hours. And we believe they've been around for millennia in indigenous cultures and throughout human history. And research with these compounds, and examples are psilocybin from specific species of mushrooms that we do research with at NYU, and Johns Hopkins does in other medical schools. Also includes LSD that was used widely in the 60s research. When done in a proper setting, and we could talk about that today, in the proper setting, it can reliably generate this very dramatic shift in awareness that we've called, in terms of the research, a peak or mystical experience, identified by incredible sense of transcendence, an incredible experience for those who are dying, that the transcending this body as we know it, and that experience of, I'm not just my body, I'm not just this cancer, I'm something more enduring. There's something more complicated and enduring about maybe consciousness that we can try to dabble in today as well. That consciousness, or whatever it is that I am, might continue in some way. Insights also included an incredible sense of gratitude for having lived this one life. So other features are a sense of a sacredness, a sense of ineffability, hard to describe this incredible altered state. Um, People describe the experience of love very often, which is remarkable to hear in a scientific setting. Um, and it's interesting because in a way it begs the question, are we wired for meaning? And I think we are. These experiences have been happening throughout human history. They form the foundation of the major religions, that the major religions are this mystical core, so to speak. And you see these experiences written throughout time by religious leaders, by poets, by everyday people. There's a Pew study recently that showed 49% of Americans have had some kind of peak or mystical experience that we could access other ways as well. And when accessed, we're shown in our research that there's a dramatic reduction in anxiety, depression, hopelessness, demoralization, and an improved quality of life and sense of well-being. And those findings were shown both at Hopkins and at NYU in two 2016 papers, that with one dose of psilocybin, but more importantly, one experience with the psilocybin generated these dramatic changes in those often difficult experiences of depression, anxiety, hopelessness. And now we're moving forward with other trials. And I hope, Michael, that in 5 years or so, hard to predict everything these days, that these medicines are rescheduled, meaning federally allowed for a variety of clinical indications, not to go out and get it at your local CVS on your own, but to go to regulated centers where people can sit with trained therapists, which we use in the trials, to have this experience and hopefully mitigate that suffering that is so common with terminal disease.
Let's talk a little bit about the research, more specifically, because many people know that there was a lot of research done in the 50s, 60s, and then stopped kind of abruptly and dramatically. And psychedelics got a really bad name for a while. And now it's started again. And this isn't a bunch of people, on a camping trip messing around with magic mushrooms. You've done hard, fast, deep science, and you have a new study coming out that is pretty remarkable and enters the palliative care space in a really meaningful way. Can you talk a bit about that?
Sure. And just to jump on what you just said, and to echo that, right, this research began in the 1960s, even before a bit in terms of the medicine being used in research. And back then, these were legitimate studies with people with terminal cancer. Sadly, the medicines became outlawed culturally because they were culturally available, but more importantly, they became out of the reach of researchers because of the cultural events of the 1960s and a host of complicated political scenarios. And sadly, for decades, we're not being used in research, even though they had promise in terms of treating alcoholism and end-of-life distress. So yes, we've returned with the research in the past decade or so with these findings. And again, yes, these are FDA-approved clinical research trials in medical schools with scientific protocols and randomized, and the findings have been very, very welcome and dramatic in terms of the reduction of suffering, like I mentioned earlier. Going forward, there's a number of trials happening. One trial that I'm involved with some colleagues at UCLA and UCSF, Charlie Grobe, Brian Anderson, Alicia Danforth, is utilizing psilocybin in a palliative care setting at a multi-site trial with multiple sites. The unique thing about this new trial is that we're bringing the research out of just cancer distress to include all diseases that affect people in palliative care and at the end of life, and also to bring it out of just psychiatry and to place it in, to house it within palliative care. So ideally, in 5 years or more, or maybe less, these treatment models, which they are, and they include preparation of the participant, of the patient, in a very careful way that's important. The medication session, which is carefully interpersonally supported and guided with trained therapists, and then a period of integration, of addressing what actually happened to implement those changes in life. And we hope that will be a model down the road in terms of end-of-life care. But I really want to highlight that model versus just the medication. is this model of preparation, careful dosing of the medicine, trained guides or trained therapists, and then, of course, this post-dosing integration period.
Yeah, I mean, it's pretty thrilling to think about palliative care physicians having firsthand experience and being trained in these modalities with, the thing on the near horizon of it hopefully being rescheduled and available to more people. So
really, and I'll just jump in real quick just to jump in with that. It is exciting, and there's been advances in psycho-oncology, palliative care. We have better targeted chemotherapies. We're better at pain control. We've really improved the life of the end-of-life patient in a variety of ways. But there's still a paucity of ways to treat this distress, this angst, this fear that accompanies the end of life that is hard to reach. Medications don't always address that. Pharmacotherapies don't address that demoralization experience. They may quiet down some symptoms of anxiety and depression, and they're needed in many cases. They're effective medications like antidepressants and anti-anxiety agents. But these medicines are not a typical drug study per se. It's taken once. But it's that experience of moving into the suffering directly. People are encouraged to move into the experience, to the unfolding changes in consciousness that provides this healing, to use that word. And again, it comes back to what we briefly talked about earlier. Are we wired for meaning? Because this healing takes place naturally within consciousness. And what does that say about our own consciousness and capacity to heal ourselves when moving into these experiences versus just taking a medication to quiet down an unpleasant symptom?
I want to just really pause at this because it's important for people to understand morphine, antidepressants, very different, medications than a psychedelic medicine, especially when it comes to this notion of well-being. We had Dr. Ira Byock on last week, and Dr. Gabor Mate on the week before on these sessions. And Ira really talking about how do we live well, how do we die well? And I think, just your reflections on what is capable, what we're capable of when we do go through one of these treatment models, if they're right for us. They're not right for everyone.
No, they're not right for everyone. And again, yes, it's a paradigm shift in how we treat suffering at the end of life. Again, I mean, it's important, and you're right. We can't overstate this. Other medicines people they take every day to reach a desired effect, hopefully a reduction in depressive or an anxiety symptom, and they're well needed, and they're a major part of mental health and psychiatry and human life. But these medicines are different. They're taken once, and it's that experience that's getting at the underpinnings of the suffering, which is this incredible fear and understandable distress about the end of this life. And by moving into this very altered state of consciousness, this mystical or peak state, people are finding so many insights, Michael, and it would go beyond this half an hour, because all the experiences are different in some ways, although there is kind of a common theme. One theme is this potential insight into what is consciousness, what is self, as I mentioned earlier, and that's recalibrated and changed and provides relief to many people. The other is a profound sense of gratitude and of the capacity to be in the moment, which is so hard for all of us to do throughout life, not just at the end of life. Most of our suffering is worrying about what happened yesterday or, in the past, or what's about to come tomorrow or in the future. It's hard to stay in the moment, which is the heart of course, the whole movement in mindfulness and spiritual approaches. But these experiences, not just the medicine, but the experiences really have shown in these clinical trials to allow people to have a better sense of equanimity in the moment and be with others in their life. And also features like forgiveness are talked about, Michael, and it's very touching to hear people offer forgiveness to those throughout their life, even people from 50 years ago who may not be here any longer, but to forgive those who they've had long-time resentments, forgiving oneself for all the ways in which we fall short in our lifetime. And again, the sense of gratitude. So it's a host of features that, And I want to point out they're not always easy. People often hear researchers talk, and they see these incredible results, but it's not all peaches and cream. These experiences are difficult, as one has an encounter with the self, I guess to paraphrase Carl Jung. And there are difficult stretches in the experience, as one is revisiting maybe prior trauma, encountering myriad things that come up in their consciousness, but with the proper preparation and the support of these two therapists in the room, they're able to move through that, and we encourage them to move into those experiences. And typically there's insight and teaching that comes up, but it's important to note that these aren't taken out of some context and they just provide this magical belief, or relief, but it's part of a very serious model, and it can be very, very difficult and psychologically anxiety provoking during the experience.
Yeah, and well, so let's pause there on the idea of safety. So something being hard, something being a challenge is one thing, but for a long time we were told that LSD and psilocybin would make us crazy or would make people jump off buildings. A lot of misinformation. When a lot of people say they're inherently safe, what is your perspective on the safety of psychedelic medicine? And I know that's a broad, we're talking about a lot of different substances.
But it's important, right? In terms of, so you're right, there was a lot of misinformation that came out of the first wave of use, half a century ago culturally. Well, we know about psilocybin through myriad trials, and we're still looking into it. We're not done with our safety and efficacy understanding of all this, is that medically, they're reliably safe for the most part. There is some increase in heart rate and blood pressure, so we do screen out people. We do monitor medical, data throughout the trial, throughout the session in terms of heart rate and a variety of medical, how they're doing physically, but reliably safe for the most part when screened out properly. The risks are psychologically. When done out of this setting, a lot can come up. If people aren't screened properly and there isn't a proper intention, which we cultivate in these studies, they can be quite disorienting to the unsuspecting person. So, but medically, we're finding in our trials they're safe when done properly, and people are screened properly. And there is screening for medical and psychiatric rule outs and rule ins, and there's monitoring throughout the trial. So, that's our job here, to really understand and examine efficacy and safety. So when these medicines are hopefully rescheduled and at some time have a role in end-of-life care, we know how to administer them and how to really utilize this model.
Yeah, and if we look at it in contrast to the quote-unquote safety of a lot of other medications that are currently administered on the market, they look pretty like a pretty safe option.
Right. I'm not a physician, but medically they're safe. Yes, and other medications aren't always so safe. And again, to drive home this point, it's a paradigm shift in how we treat people. It's not just quieting down a symptom; it's introducing, ideally, this change in awareness of what's actually happening, the big questions: life, death, consciousness. Affecting their interpersonal life. It's very different than this quieting a symptom versus changing it from addressing the suffering beneath it, and finding meaning. Viktor Frankl, I always try to quote his wonderful book. I mean, these people have cultivated a sense of meaning through these transcendent experiences that are just really very interesting. And we're looking forward to the next 5 years of additional trials. And as you know, better than most people, we need treatment models to address this fear and this anxiety that is part of this life cycle, but needs added effort.
Yeah, well, and there's a great question from an attendee, which don't know I'm thrilled to ask. Must one be cognitively whole to benefit? In other words, could this also benefit dementia or otherwise cognitively impaired patients?
It's a great question, and it's still being explored. In our trials to date, we've ruled out cognitive impairment or Alzheimer's, things like that. But there is quite a robust conversation in the research community could these medicines be helpful in those clinical disorders, maybe at a more milder presence than a more robust one. So far we've not included that, but there are people exploring the possibility of that. Could it be helpful even with some cognitive impairment? So the jury is still out, and we look forward to the further research.
Well, it's one of the things it does well is synaptic connection, right? Which is
Right.
one of the things that breaks down in dementia and Alzheimer's. So,
Right. There's hope that the brain implications may affect and clinically improve those symptoms. But again, they haven't happened yet. But I think the next 5 years, 5 to 10 years, are going to be so exciting in terms of the various ways that these medicines are being looked into.
yeah, so there's multiple questions coming in from death doulas, other clinicians about access. Is there a way to get patients into trials? Is there a way to get an individual into trial? Is it a wait and see? How do people start to find benefit other than reading about the research?
Yeah, it's one of the harder parts of doing this work for all the researchers is all the emails we get from people who are suffering, asking how do I get access to these medicines, and it's difficult because there's no easy answer and easy access. So these medicines so far are available in these FDA-approved clinical trials. There aren't many of them. There've been 3 to date published, and there's a few others emerging soon. One was just finished. In a clinic outside of Baltimore. So these are still not legally available federal agents to use. So there's no easy answer for that, and it's that I'm disheartened to say. But hopefully within years they will be available again after these future trials in palliative care. In terms of what trials are available, I'm happy to send you, your site as they come up to post trials that are available for people to look and access and apply for. They will be happening more over the next year, and more than happy to share that with your website, Michael, as they come.
Great. Well, and please do, and to everyone listening, we will put out it on our social channels when these trials are happening and the way to get access to them. So we've got just 3 minutes left and a lot of questions from everyone, obviously. But let's talk about this notion of agape or cosmic love. And you've touched on it, but this is one of the unique elements of this medicine.
Yeah. It's been the most poignant part of the work, sitting with people who have these experiences and being present for the experiences they talk about. It is quite poignant. And that's a language you don't find in typical psychiatry research. So this mystical or peak experience, this change in consciousness, really has shown in these trials, and as well as the first wave of research 50 years ago, to invoke this sense of there's a greater meaning or a greater sense of love, or agape, to use the Greek word, which I love to use as a proud Greek American. That is the very ground of being, that there's something about consciousness or self that has access to this incredible sense of forgiveness and love, or to use the word agape, or some kind of cosmic love. And when people discuss that, it's very poignant. I'm sure you've seen and people have seen in the press, and I could send you some things to post on your website as well of patients talking about this, the sense of eternal love that really changes, it recalibrates their experience here on earth and how they treat others. And interesting to point out, those experiences, Michael, are also seen in near-death experiences. People with NDEs who have died on a surgery table, and then heart has stopped and they return to consciousness, report a very similar landscape in terms of this love. And we see it also in, of course, other parts of our lives. And that's touching. And that's important. And, past all the scientific measures we do, that's what comes through so often when people talk to us, is that experience. And that they report it changes dramatically their experience of death, whatever that might be, of consciousness, whatever that might be, but and importantly, their time here on earth, which is limited. which is limited for all of us.
Yeah. Well, I've started to think of end of life as a period that can be about great healing. It's not just the end of our lives. It's not just battling whatever we're battling, but I just flip it in my mind and say, oh, we've entered a moment of great healing in someone's life because so much is available.
It's a great way of looking at it. You mentioned Ira Bayek before. We did a lecture recently at a different event where he was framed that as a developmental stage. Right. It's just another phase of this life and an opportunity to learn, to cultivate insight, to hopefully grow and heal, versus the idea that it's just this dreaded end that's there at the end of our lives. For all of us, it's kind of sitting there since we're kids, this thing at the end that we don't talk about as if it wasn't part of life, but it's a part of life. And to echo how you're phrasing that, maybe a time to learn, maybe a part of life that's profoundly important versus just the end of this experience. As you know, 100 years ago or more, people died in the community. It was part of the life experience. Only with modern medicine has death been pushed out of kind of, behind closed curtains and doors, as was birth as well, as if birth and death are a part of life. And now, with end of life doulas and birth doulas, birth is celebrated, obviously, and as well as death. It's part of the life cycle. So I appreciate the way you phrase that, because it is another and maybe the most important part of our life to learn. And it seems death is our greatest teacher, and has been.
That's it. Strong medicine.
And by the way, I think COVID has taught us that. I mean, despite the unspeakable suffering of these past remarkable 2 years, it's pulled the curtain back on what we already know, but it's really reminded us in a very acute way that, impermanence and death and dying and suffering is just right around the corner. And by avoiding it doesn't really help us. It actually only fuels the anxiety. But by moving into it and walking with it, we find hopefully healing and insight. So as the great religious traditions often address. So an incredible 2 years, but hopefully it raised awareness about these important issues.
Absolutely. And for those listening, you teach a thanatology course. Where can people find out about that?
Okay, so the Open Center in New York City has every year a 6-month course, a weekly lecture for 6 months. The new one starts in February of 2022. They can go to the website. And it's a wonderful course with different lectures on different aspects of end of life, thanatology. It includes also me speaking a bit about these medicines and this research. So invite people to go to the Open Center, whatever the website is, I guess opencenter.org, but they can find it. And thank you.
Yeah, of course. Well, I want to just honor you for not just the brilliance of your work, but the bravery and the courageous nature of what you've been doing. You were a pioneer in this space, and I'm sure it hasn't been easy. So thank you, Tony.
Thank you for your work, and I'm grateful to be part of this ongoing conversation.
All right, everybody, we've been here with Dr. Tony Bossis. Some of you had trouble getting in today, for which I apologize. You will be getting a recording of this chat very soon, so you'll be able to touch on the parts you missed and come back next week. We've got Ask the Doctor every week. The Chief Experience Officer from Cleveland Clinic, Adrian Bossis, is coming up next. Lucy Kalanithi, Sunita Puri, Tracy Gaudet, extraordinary wisdom every week here. So thank you, Tony. Thanks everyone for showing up. Thanks for your questions. We'll see you next week.
Bye.